Dr. Amri, you can start now.
Assalamu alaikum. Good evening, everybody. Tonight, our webinar going to be over a very interesting subject, which is the liver metastasis from colorectal and non-colorectal cancer. Our star speaker tonight is the well-known Professor Hans Rudolf Rapp. Is our visiting professor to Saudi German Hospital Group. He's the head of the department in Oldenburg Hospital of the General and Visceral Surgery since 2002. He's the Vice Dean of Faculty of Medicine and Health of Science in Karl von Osinski University in Oldenburg. He is also a regular awarded as a top surgeon in the list of recommendation of national press in Germany. Me, myself, I'm going to play the role of the moderator. I'm Ammar Dehlawi, assistant professor from Qura University and hepatobiliary and liver transplant surgeon in Saudi German Hospital. I would like to also to welcome our panels today, Dr. Nadim Malibari, assistant professor and colorectal surgeon from King Abdulaziz University and Saudi German Hospital in Jeddah. Dr. Basim Seed, assistant professor and head of the Department of General Surgery in Saudi German Hospital in Riyadh, and Dr. Ihab Anwar, a surgical oncology consultant in Saudi German Hospital in Cairo. I would leave the mic now to Professor Hans.
Yeah, thank you for the nice induction. I'm talking about the liver today, and this is a very amazing organ. As you might know, it is in former times thought to be the seat of the life force. Therefore, it is named liver from Old Indo-Germanic word family Leben or life or live. It is named in Germany and in England Leber or liver. In Italy, if someone has courage, they don't say he has guts, they say he has liver, affigato. And therefore, it's a very special organ. And I want to go through 6 steps to tell you something about at first the anatomical and technical basics. Then main part is our topics on colorectal metastasis. Then I will say something about some aspects of non-colorectal metastasis, how to deal with irresectable or initially irresectable metastasis, and will try to explore some parts of the territories beyond the frontiers, and end with some take-home messages, or in Corona times, I should say, some stay-at-home messages. So let's start with basics. The liver is divided in 8 segments, 4 for the left part of the liver and 4 for the right part of the liver. Each 2 segments from cranial caudal extension are named a segment. This is the right lateral segment, this is the left lateral segment here, and these are the 2 median segments. And we can now do surgery along the borderlines of the segments or do atypical resections. Before we do this, we should mention the principles of liver resection. Before doing liver surgery, we should have examinations, not only a CT scan, but also an MRI, at best with a liver-specific contrast media. 3D reconstruction is for selected cases. I will show you an example later. We need for the operation intraoperative ultrasound, so we can see the metastasis in the liver live through the operation and can decide about where to cut immediately. There are functional demands. If we take away a part of the liver, must be residual parenchyma which is sufficient for the function, which means the liver needs blood supply via both sources, the artery and the vein, and the portal vein, and a venous drainage, which means at least one of the three hepatic veins, and of course a bile drainage. There are different possibilities to dissect the parenchyma and control bleeding. This is routine, so that blood transfusions nowadays are or should be an exception. As I mentioned already, we can do atypical resections, which means subsegmental, less than one segment. Some call it wedge resections. We don't do enucleations of liver metastases, but sometimes wedge resections with a safety margin. Then we do anatomical resections along the frontiers of the segments, bisegmental resections, right or left hepatectomy, or even extended hepatectomies like trisectorectomy. This is shown here. This is a schematic picture of the liver with 8 segments. Segment 4 is divided in 4A and B. And then you can see this is a left lateral resection, segments 2 and 3, or a sectorectomy, a left sectorectomy if you want. Right hepatectomy includes segments 5 to 8, and so on. How to dissect the parenchyma? There are several possibilities with ultrasound dissector with just suction and clips, or what I mostly prefer is the ligature device. Since I took ligature for parenchyma dissection, I never used clips longer. Access is possible via open surgery. Every liver surgery you can do open, and some you can do laparoscopically as well. And if you do it open, there are several possibilities how to make the incision. I prefer such an angulated upper midline and right transverse incision for most of the open procedures. You can do it laparoscopically, as I mentioned. This is these are slides from the Memorial Sloan Kettering Cancer Center in New York. They did a comparison between open and laparoscopic and found what is not astonishing, that the operation time is longer with laparoscopy, but you have less blood loss, shorter hospital stay, and lower morbidity. Nevertheless, this wasn't a randomized study, and therefore we can assume that there's a strong selection bias. I think laparoscopic resections are for the minor procedures and not really suitable for most of the larger resections of more than 1 or 2 segments. An easy example, which can do laparoscopically as well, solitary metastasis in segment 6. This is fairly easy, like a appendectomy for the liver surgeon, I would say. You can see here how it looks after the resection. This is a segment 6 resection, segment 5 and 4 are still in place. And the specimen is the entire segment 6 with really large safety margin here. This patient has a very, very good chance of cure. In other cases like that one, there was an infiltration of the right liver vein. Therefore, we had to do a right hepatectomy with a preliminary dissection of the vessels, the right artery and the right portal vein. Then you can see here demarcation of the right lobe and can dissect the parenchyma along that line. And this was the tumor close to the vein, a little deeper. The vein was infiltrated. These are the usual routine cases, but this is not all we do or we can do. We shall look a little deeper into colorectal metastases. Some medical oncologists doubt whether this makes sense for the patients or whether all what we do is selection and the patients would survive as good without surgery. That this isn't true was shown by a guy from Erlangen, Johannes Scheele, who could show, he compared from the Erlangen patients the curative resections with the non-resectable patients, and not astonishingly, he found that difference. But then he did something else and looked for those patients who were resectable, but for this or that reason were untreated. And he looked what happened with these patients which could have been resected but weren't. And these are slightly better than the not resectable patients, but all are dead after 5 years, as you can see here. This is a very good proof that this is not selection. Otherwise, the red curve should have been here. In my early years in Hanover Medical School, I looked for our results and could show that even an R1 or R2 resection of the liver is beneficial for the patient. If there's no other way, best is R0 resection, as you can see here, but R1 or R2 resections are still better than doing nothing, the blue curve here. This is very important and was shown also by others, that in doubt, if we cannot do an R0 resection, it is better to do a partial resection or probably, hopefully, in R1 resection only, than to do nothing. Liver resection now has 5-year survival rates of roughly 50%. This is partly selection, yes, but all these patients wouldn't survive, or most of them wouldn't survive if we wouldn't do that resection. A lot of scores were proposed to estimate the risk for a patient or the chance for cure for a patient. You can see several variables were used in different ways. The most popular, I think, became the Fonck score. And you can see the Fonck score uses clinical criteria, and you can get 1 point for each criterion. Lymph node metastasis, interval between the resection of the primary and the liver metastasis, number of the liver metastasis, preoperatively, of course, as the preoperative CEA level, and the diameter of the largest metastasis. For each, you can get 1 point, and 0 points are good prognosis, 1 to 2 an intermediate, and 3 to 5 a worse prognosis. And you can see in that slide, which I got from Frau Altendorf-Hoffmann, that the Fonck score discriminates the prognostic groups quite well. Group 1, 2, and 3 is the worst, but even the worst group with the worst Fonck score has a 5-year survival rate of 30%. And that means that the Fong score is not a suitable means to exclude patients from liver resection. You can use it to estimate probability of survival, yes, but you cannot say, or should not say, a patient has a Fong score of 4, then we won't operate on him. This is not justified from those data. In overall, resection rates increased over time to now 20-25%, but it could be up to 50% or even more. If we look on different centers, we can see a large difference between non-specialized regional hospitals here, with a resection rate of liver metastasis of 22%, and the liver centers with a resection rate of 47% roughly, which is even more important because you can imagine that the most difficult patients are sent to the liver centers. And despite this bias into the other direction, we can see a nearly 50% resection rate here in the centers. But in total, only 26%, which means that most patients are still operated in non-specialized centers. I think we should think about a better organization of this. Former contraindications are still in the heads of people, and especially of some medical oncologists, saying you shouldn't do a liver resection if there are more than 3 metastases, if the safety distance is less than 1 centimeter, if there's extra hepatic tumor, or there are recurrent metastases. Nothing of this is true, or not really true, concerning the both points here. There's no evidence to support the meaning that this is a reason to exclude a patient from liver resection. In that trial, no difference between 1 to 3 or more than 3 metastases. In that trial, another one concerning the number of metastases, we see that patients with 4 or more metastases are at least as good as those with 2 to 3 metastases. Patients with 1 with a solitary metastasis are better than the others. This is clear, but these are 10, 15 years here. 5-year survival is at least a quarter of patients, and this is by far better than you can reach it by any other mean. Safety distance is not really important. Only a slight difference between 0 to 9. This is not significant to a centimeter or more. Again, another trial which could show only an actually positive margin is disastrous in the end. If there was no significant difference between these 3 groups, 1 to 4, 5 to 9, or more, 10 or more millimeter safety distance. Therefore, this doesn't play a really important role. If you can, try to have a centimeter or more, but if not, it is enough to have less than a centimeter safety distance, as long as the tumor is totally removed. Extrahepatic tumor makes a difference, yes, if there's extrahepatic in all these patients, also with non-colorectal metastasis, they are doing worse if there's extrahepatic tumor, but again, not so worse that you should exclude them from surgery. Again, nearly 25% survival after 5 years. Liver metastasis, especially with resectable lung metastasis, this is a special group, are doing even better than other extrahepatic locations of metastasis. If you can resect both, you should do this. In this study, they got a 5-year survival of 35% for that group of resected lung plus liver metastasis or liver plus lung metastasis. Recurrent metastases aren't a contraindication as well. You can see if there is recurrent liver metastasis, the curve is in that study roughly the same as for the primary resected patients. You can again say, okay, this is selection. Yes, perhaps, but obviously a good selection because nearly 40% of these patients live after 5 years and are rescued comparing to doing no reoperation. We are doing second, third, fourth, or fifth resections for liver metastasis with the same results as you see here. So what are the proven facts? Liver resection improves survival. This is very clear. The chance of cure by R0 resection is about 25 to 45% of all patients with metastasis, depends on selection, but there's a realistic chance of cure only after R0 resection. No means of chemotherapy, of thermoablation can give you the same results as surgery. Show you a few examples of difficult resections, but what we are doing in our daily lives. This is a segment 4 resection, where you have to thoroughly dissect structures in the hilum if you want to keep segment 1, 2, and 3. Then you need it in that case to do an anastomosis between the bile duct and the small bowel. Another case with the right sectorectomy, only segments 2 and 3 are left, and the fatty liver in addition, plus a resection of the portal vein, and the bile duct artery is here. And here you need again an anastomosis. The third example with diaphragm resection and resection of the cable vein with an interposition. This was an extended right resection as well, but a part of segment 4 is still in place. Now, what's about the non-colorectal metastases? It is clear that the neuroendocrine tumors are doing at least as good as colorectal metastasis. If R0 resection is possible, 5-year survival is 50%, and then most of these patients are cured. R1, 2 resections are worse, but still beneficial for the patients. This is comparable to colorectal metastasis. Therefore, we have to look for the non-colorectal, non-neuroendocrine tumors. But we are doing those resections as well. A few examples I did by myself. Malignant melanoma resection here. Huge malignant schwannoma. You can see at this example that if you won't do the liver resection for that case, he will be dead in the near future because the tumor was really fast growing, and we couldn't cure that patient, but he lived 6 years after that operation. Other example, thyroid cancer, also a huge tumor on the right side and one on the left side, a smaller one. We did the resection, sort of extended right resection as well, plus left resection. And that patient astonishingly was after 5 years still free of tumor. Then we lost him out of sight. In my early years, I analyzed the tumors in Hanover, the non-colorectal, non-neuroendocrine tumors in Hanover, and found 2 groups: a better group with breast cancer, malignant melanoma, gastric cancer, lung, and small bowel cancer, which had a 5-year survival after arterial resection of nearly 40%, and a worse group with sarcoma, pancreatic cancer, and renal cancer with 5-year prognosis. But a little bit better in the curve, in the area under curve for the R0 resected than the R1-2 resected patients. But also this became better, new data, these were older data, new data for renal cancer from my old institution, the Hanover Medical School, were just published this year. And you can see there is improvement over time. Now, this is not really good, but 20 or 22% 5-year survival is disease-free survival is better. No, this is disease-free survival, and overall survival is roughly 30%, I would say. This is better than in the former years, but still not what we want to reach. It is mostly due in these renal tumors to the extrahepatic metastases. Those patients without extrahepatic metastases are doing really well with a 70% 5-year survival. Therefore, you have to really think about doing liver resections in patients with extrahepatic tumor. But if there's no extrahepatic tumor, even in renal cell cancer, you can help patients with liver resections. In breast cancer is one of the out of the better group. My own results weren't in the former years were only close to 20%, but over time they got better, and now there was a publication of astonishing 61%. This is a comparison of, let's only look for the 5-year survival of the results, the 5-year overall survival results for the different entities of common tumors who make liver metastases. And you can see here in breast cancer, as I mentioned already, 61% is possible. In renal cancer, from France, from Adam in France, 38%, gastric cancer 42% at best. Even pancreatic cancer, there was a study with 25%, or here in melanoma 39%. Again, you would say this is selection bias. Yes, again, yes, but if you do this selection in a good way, then you can help at least a good portion of these patients. And I would say you shouldn't withhold this therapy from patients who are suitable to be operated. What are we doing with initially irresectable metastases? There are lots of possibilities, but not all are suitable. Transplantation would be an option, perhaps. There are different results in literature. We did a series in Hanover as well with transplantation, with not such good results. 80% got metastasis in their new liver, but it isn't possible to go deeper in that issue because actually there's no chance to get an organ nowadays for liver metastasis patients. Local destruction like microwave ablation, radiofrequency ablation has, as far as we know from the studies, no realistic chance of cure except for a few patients. Lit is out, I would say. The other microwave or radiofrequency are for some reasons better than lit, and I think with the new devices, microwave ablation is in the first position now. So let's look for the other two options: neoadjuvant chemotherapy or extended possibilities of resection, like stage procedures, split procedure, or this will be my last point, the hypothermic perfusion of the liver. But this is a field where we can do, or we can help the patients realistically. This was proven by Adam. Again, he was the first to publish a very good conducted study with neoadjuvant chemotherapy, and could show that so-called unresectable metastases can be made resectable. These are some of his pictures, impressive pictures showing like these tumors can shrink to only a small extent of their former diameter. This shows that this is irresectable and this is resectable. Not in the old borderlines, of course not, because in the old borderlines they weren't resectable, but afterwards they are. This is one of our patients where I thought that this is even worse than that, because here you have countable metastases, large, yes, but countable, and you can still dispute whether this really isn't resectable here. But this, everyone would agree that this is irresectable. These are multiple, nearly uncountable metastases, and I wouldn't have thought that we could resect on this patient, but 1.5 years later, same patient, same height of the liver, same picture. Just in between these pictures are 1.5 years of chemotherapy, and there are only few remnant metastases which could be resected quite easily. This is impressive, I think, as well. And Adam could show that of all patients, 23% were resectable in his institution, and he could add another 10%, which is roughly 40% more than initially, to an overall resectability rate of 33%. Of secondary resectable, 12.5% in that publication, and there were 4 independent prognostic factors to say whether the patient will be resectable or not after chemotherapy. The primary in the rectum was better than the primary in the colon. More than 3 metastases were worse. Greatest diameter more than 10 centimeters was worse, and high CA19-9 level as well. If you ask how did these patients resected after chemotherapy compared to those who were initially resectable, you can see they did a little bit worse, but in the end, after 10 years, curves are not so far from each other. This means you can create long-time survival with neoadjuvant chemotherapy in primary unresectable patients. The primary resectable patients, the colleagues from France did another study for with neoadjuvant chemotherapy for resectable liver metastases, but couldn't show success. This is a curve for the disease-free survival. Something happened here, what I cannot explain, but the curves are not different from each other, and the overall survival isn't different as well. Therefore, up to now, we would say there's not really a place for neoadjuvant chemotherapy for resectable liver metastases, because chemotherapy is not for free. As Fong wrote here, cash costs, which means that cash is from irinotecan, and oxaliplatin causes more sinusoidal congestion, which causes the blue aspect of the liver, so-called blue liver. These chemotherapy agents harm the liver, and this is not without consequences after the operation. In that study, 2 groups, a chemotherapy, neoadjuvant chemotherapy group was compared to a control group without chemotherapy, and they could show that overall complications were significantly higher in the chemotherapy group, and they could further show that with each cycle of chemotherapy, the morbidity after the operation increases. Therefore, we have to think about neoadjuvant chemotherapy and not let it pass if a medical oncologist says, yes, let's do neoadjuvant therapy in that patient. There are also patients like that lady who are progressive under chemotherapy. We sent her to chemotherapy because there are thousands of metastases. This liver looks like the tumor is exploded in the liver, but she was progressive under chemotherapy, and she was 78 years old, and told me, what shall I do? I have to take care for my husband. He cannot live alone. I have to be there for him, do something. And therefore, only segments 6 and 7 were free, actually. And then I did in her this extended left resection, and was surprised by myself that she survived 5.5 years. She didn't stay tumor-free, got new metastases, but slowly in the remnant liver, and could be there, was in a good condition, could be there for her husband until he had to go, and this was what her last important wish was. And there are, I would say yes, this is close to the borderlines here, and I wouldn't do this as a daily routine, but in selected cases, I wouldn't hesitate to do this again. In other cases, there is a possibility to do a staged hepatectomy. If we have both sides with liver metastasis, we can operate at first on the one side, and then after enlargement and perhaps dissect the branch of the portal vein to the other side, and then this side will enlarge, and after enlargement of this side and shrinking of the other side, we can do a second stage of liver resection. Same we can do with split resection, splitting the liver at first and dissecting the vein, and then after 2 weeks or so, go again into the situs and resect it definitely. Doing so in that trial, the results were by far better than anything else what you can do alternatively. If this is a difficult situation like this, we can get help nowadays with printed 3D models of the liver. We get these in original size, like we find it in the body. This is an example, a 50-year-old man with 17 metastases in all segments, but in segment 1. I thought at first it wasn't resectable. This is the situation after chemo, after neoadjuvant chemotherapy, and he got lots of chemotherapy with only few success. 2 metastases in segment 2 and 3, and 2 or 3 metastases in segment 8. So we planned to only subsegmental resections in these segments, and to resect all the other parts, segment 4, 5, 6, 7. And these are the metastases, and we get help then from the possibility to virtually plan the resection at the computer with same model, only virtually. We can make structures visible or invisible as we like, with by put them on or off. Here we made the parenchyma invisible of the left lobe, and saw the single metastasis, here segment 8. And we have a second life-size model without the parenchyma as well, which we can rotate in our hands and look for all the vessels. Still the same patient here, with all the vessel structures. We wanted to keep segment 8, and therefore we have to look for an arterial supply for segment 8. And this was difficult in that case. This is, these are the 2 metastases in the left lateral lobe. But this is interesting, how to deal with the arterial blood supply of segment 8. If you're looking, this is a surgical view intraoperatively. You see the main hepatic artery, the left and the right. And you could think about that perhaps this branch is one that goes to segment 8, or this is that one or this one, but you aren't sure. And actually, It was the other way around. Neither this nor this nor this were branches to segment 8, but that one behind. And then we went back to the virtual model and could see this is the common, the right artery, these are the 3 branches, and only the last one went to segment 8. So when we operated, we had to dissect these 3 branches and preserve the last one. Therefore, this model was really helpful in preserving segment 8. I would say I wouldn't have I weren't successful if I wouldn't have had this possibilities here. Now, what is beyond the frontiers? I would quote Shakespeare here: diseases desperate grown by desperate appliance are relieved or not at all. Therefore, we thought about, and this was mainly Rudolf Bichelmeier, my teacher in Hanover, thought about what else can we do to extend resectability. And he invented these 3 possibilities and named it with a hypothermic perfusion of the liver, named it in situ perfusion, antesitum, which is a little bit wrong Latin, but it means that you divide the caval vein above the liver and keep the other structures in place, or a total ex situ resection where you put the liver out of the body, like in a transplantation, and retransplant it after the resection in a bowl. This is one of these patients. We operated that way, ex situ liver resection with very complex reconstructions of the vessels which were infiltrated by the tumor. And you can do this then in a bowl with iced water and have all the time you need to do these reconstructions here. Survival after these complex procedures is, of course, worse than after a normal liver resection, but 20% patients with a long-term survival, at least. This is nothing I would do on an everyday basis again, but we could keep in mind that for selected cases, it might be a possibility to do. What did I want to say during this talk? Surgical resection of colorectal liver metastasis, also extended sometimes or repeated sometimes, is useful, at least if an RCO resection situation can be achieved. For some patients also as one resection. It's possible in 30 to 50% of all patients with colorectal liver metastasis, and means a cure for at least, depends on selection, at least 25 to 45 or even 50% or more. For many others, it is a good, perhaps the best palliation they can get. Surgical resection of non-colorectal, non-neuroendocrine metastasis remains an individual decision so far, but I would say it is useful, at least in selected cases. Means of thermoablation are methods of second or third choice, especially microwave or radiofrequency ablation, no longer lit. This is out. And multimodal concepts of therapy may improve results, especially as a neoadjuvant chemotherapy of unresectable, initially unresectable or borderline resectable metastasis now neoadjuvant therapy as a routine for the resectable patients. This was the main sentence behind this is the main message is patients with liver metastasis can be cured. And I will close my talk with a very old quote from Aristotle. He already knew that medicine is perhaps based on natural science, but isn't really a natural science itself. It belongs to the humanities as well, and therefore he told us 2,500 years ago, not the human being in general is treated by the doctor, but the Callias, the Socrates, or another sick person. If now someone knows the theory, the general, but not the special aspects of the individual case, he will often miss the right treatment because therapy refers to the individual case. Thank you for your attention.
Thank you very much, Professor Hans, for this very nice talk and very nice presentation about the liver mets from the colorectal and non-colorectal liver cancer. And we'll move the mic to our panels if they have some question. Dr. Ehab Anwar, please.
Yeah. Professor, I really enjoyed your lecture. It covers everything. It's a very surgically oriented lecture, which I really like. I enjoyed it, so thank you very much. I just wanted to add or take the panel through a different angle. Maybe I would like the opinion of yourself and the panel regarding decision making. As you're aware that cancer surgery is no longer a surgeon's alone decision. It's a panel of people regarding the medical oncologist, radiation oncologist, and of course, even the radiologist can interfere if he can in the MDT response. So I have actually more than one question. It's just 4 or 5 controversial points. When is as you mentioned, you don't like neoadjuvant chemo. I'm not sure medical oncologists would agree because they like neoadjuvant chemo. It's the fashion now. They like neoadjuvant chemo in colon cancer, in rectal cancer, in liver cancer. They think it can cure, and with minimal, I know, of course, they damage the liver, but they say it recovers within 4 weeks, and you can operate on a lesser tumor. They can make a resectable tumor resectable, or they can make it completely disappear. So where do you find the line? And there are new areas there are 3 modalities, the FOLFOX and the PRISMA and the other ways of new neoadjuvant chemotherapy, which can be effective. So where do you draw the line with the discussion with the medical oncologist during the MDT to say, no, this is a surgical, only a surgical resection patient? And that brings me to the second point, which is, if they succeed and give neoadjuvant chemo and you have 1 or 2 metastases, they're completely gone. So they have complete response. So what would be your reaction after that? Although maybe that's rare, but what would you do? Would you still go for surgery or not? And is there still microscopic remnants after neoadjuvant chemotherapy? One more point is the sequence of surgery. Some people like to do the liver first because they want to do chemotherapy for the colon cancer, or you do it simultaneously. They say it increase morbidity, especially if it is larger liver resection. So what's your view about what's the best thing to do about sequential type of surgery? Which one to do first, or you do it both together, liver mets and the colon cancer, the sequence of surgery? And if you have R0 resection, would you support postoperative chemo or not? So I've finished with my questions. I'm sorry I'm late. I'm long, but a few questions. If you can answer, I would be very grateful.
Yeah. Okay. First question was about how to deal with things in the MDT. And this is perhaps somehow easier in Germany because we have got a guideline where we can read that neoadjuvant chemotherapy isn't a routine for resectable patients, and postoperative chemotherapy isn't useful after R0 resection, despite it is written in the guideline, especially the postoperative therapy is done widely, I know. Preoperative chemotherapy we mostly agree about, and I'm with you. It is the best what you can say about chemotherapy in resectable patients, neoadjuvant chemotherapy in resectable patients, is that it mostly probably doesn't harm the patient. But we mostly agree about what to do. If not, then we write it down in the protocol that we don't agree. And mostly these patients are surgical patients, so I have to talk to them. And it is, despite MDTs, it is still the case that a patient has to decide what happens with him. We only can say what our meaning is and can advise something, but we cannot decide something as MDT. We shouldn't forget this, that the patient is the boss and decides what is done. And if there's a non-agreement in the MDT, then we can talk to the patient and let him the decision. But this is very rarely the case. Mostly we agree. Not such a problem here. Bigger problem is a patient who wasn't seen by us and got already chemotherapy when we see him or her the first time. And I say, why did he got chemotherapy for a resectable tumor which didn't respond to the chemotherapy, as we can see from the pictures? This is more often the case, but we cannot change it then. So we haven't really a point of disagreement in the MDT. Perhaps this is a lucky situation in which I am, because I have medical oncologists around me who think surgically. In other cities, perhaps other situations. But this was the answer, my answer to your first question. Second question was what to do with complete response, right?
Yes, that's correct.
Yeah. This is difficult question as well, because we know, on the one hand, we know that after complete remission from the pictures, more than 80% have still microscopic tumor in the liver. But it's difficult to find this intraoperatively. We would do everything to find it preoperatively by MRI and by PET scan, PET CT, PET MR. If everything is negative, I would tend to wait. It's also an individual decision, but I would tend to wait. If nothing is seen, even in a PET scan, then I would wait, because if I would operate this patient and remove the part where the tumor was before, then the pathologist perhaps wouldn't find something, and half a year later, patient comes with a new metastasis in another area of his liver. Therefore, there isn't a clear-cut guideline for these patients, but I would tend to wait in complete remission, which I can agree with by PET scan and MRI with liver-specific contrast media. Then you asked, what about liver first procedure or the sequence of resection? I didn't mention this during my talk. It is, I think it's worth an own talk. It's a complex topic. To make the long story short, there are cases for liver first, especially if the primary is small and the liver involvement is large. Then you can say, okay, let's do the liver at first, because if we now do a deep rectal resection and let the liver alone in that situation, then if it comes bad, the patient gets complications and anastomotic problem and needs 3 or 4 months to get in a operable situation again, and this might be too late for the liver. These are cases for liver first. Whenever possible, I would do a combined approach to resect liver and bowel synchronously. If liver involvement isn't as large as I just mentioned, I tend to say you have to go from the first source of tumor cells to the second one, and not the other way around. Okay, these were your questions, or I missed?
That's very. I really enjoyed it. Thank you very much. I appreciate it.
Thank you, Dr. Ihab, and I will leave the microphone to Dr. Nadim Malibari if you have any question.
Prof. Hans, thank you again for your presentation. I enjoyed it. Although the last time I went into a liver resection was, I don't know, 5, 7 years ago, but still, and I do agree with Dr. Ihab, the same idea. What we started doing recently in our center is we give the neoadjuvant course, chemoradiation, then we go with liver first. And as soon as we finish the radiation course, and we wait for the 2 months after the radiation, and then we go ahead and do the rectum. And I'm talking about rectal cancer. But we do liver first, then we do the rectal resection. Yeah. But my question is, you don't believe in RFA. Right. Yeah. You don't believe in RFA, radiofrequency ablation, even for tiny lesions. Because one of the things we used to do in our center, me and Dr. Ammar back in France, we do a formal liver resection, and let's say we clean the other lobe with RFA intra-op. And now what we're doing here in Saudi Arabia in our university center, we use RFA either intra-op or even before going into liver surgery with our interventional radiology. So I'm just really surprised that you're not with RFA.
If you want to do tumor ablation, I said you can use microwave or RFA. This is both possible. And for long years, RFA was the best device to use. I would say the new microwave apparatus are perhaps better than RFA because they can calculate greater diameters of tumors. But the main problem of both, of all measures of heat ablation is still heat sink. And I still see patients after thermoablation with tumors who were broken out, I would say so, broken out to one lateral side where perhaps a larger vessel was, and where heat, I would say it is perhaps possible if a patient in somehow older patients in not such a good condition comes with one solitary metastasis, which is in a good reach for RFA or microwave, and is 1 centimeter or 2 in diameter. You can do this. You can try this to spare the operation for the patient, but this is also an individual decision. Standard is the resection, because there's no heat sink in liver resection, and no tumor ever got resistant against liver resection. So if you resect it, it is gone. This is a complete remission in 2 hours.
Yeah, okay. If you were performing, let's say, whatever, a colorectal procedure for cancer, either colectomy or low anterior resection, and upon exploration, you stumble into a small, tiny lesion that looks very suspicious, let's say, in as Dr. Ammar said, do you take it out? Or
sure.
Do you biopsy?
Yeah, sure.
That's like a formal liver resection.
Pardon?
Do you take it out as a formal, let's say, segment 3 or segment 4? Not 4, but
whatever is necessary. If it is enough that it is a suspect lesion, then I take it out, of course. Sure.
You take the whole segment.
No
you
doubt.
Don't do a metastasectomy. And I call Ammar. I call Dr. Ammar, and I give him the.
Okay.
I'll let him finish up the operation.
I will be honored, Dr. Nadim.
Okay, thank you again, Prof.
Thank you, Dr. Nadim. Thank you, Prof. Hans. Also, we'll see now with Dr. Basim.
Welcome. Thanks, Prof, for this marvelous presentation. Literally, you conclude the important and target point in our webinar. And thanks, Dr. Ehab, because really you feature one important questions that I'm going to ask about the synchronous resection, to start with liver first or rectum first, but it's already answered. My second issue, as we know, the indication for resection for colorectal metastasis was expanded in last few years and became standardized. This to include large-sized tumor, multinodular, multifocal, and lymphatic inclusion to portohybrids. My question is, do you think this expanded indication should be standardized or institutional based? I think it's clear. I mean, institutional based surgeon, expertise, multidisciplinary team, or should be standardized, and patient with metastatic colorectal cancer should be transferred to another institution.
Yeah.
This is my first point. Second point, when there is extensive bilobar lesion of the liver, and we are going to do staged hepatectomy, you prefer to start with the more extensive affected loop, or the less affected loop first for our stage hepatectomy? Thank you.
Okay. I start with the last question. I would start with in a staged procedure with less affected to resect the tumor in that part, as I showed the schemes. In that part of the liver, I will keep in place later on, and dissect the portal branch to the other side, like in a, like if we do a split procedure. That means at first the less affected side, and then that side where I want to go later and resect probably all the lobe.
Okay,
This is the answer for the second question. The first question, yes, I showed a study where you could see that the resection rate of all liver metastases in specialized centers is far above the non-specialized centers, and therefore I would advocate always for doing liver surgery mainly in centers. If you have time to decide this, if there is no time, let's say intraoperatively, you find something, this is mostly not too difficult to do it in a normal hospital as well. Liver surgery in not very complicated situation is fairly easy. It's nothing nothing difficult to resect segment 6 or segment 1 and 2 or 3. This is fairly easy. And therefore, yes, if you find something during colon cancer operation, cut it away. This spares one other operation for the patient. But if you are in doubt, if you are not familiar with liver surgery, then you better send the patient to a specialized hospital.
Okay, thank you.
Thank you, Professor Hans. I would like to welcome also among the attendees the member of Saudi Society of Colorectal Surgery, our Saudi program resident and recent graduate, our friend aboard in France and in Germany, in addition to our colleagues and seniors. And here from our audience, there is a question from one of my friends, and hepatobiliary surgeon, Dr. Thamir Al-Ghamdi. He was trained in Germany, and he asked you a question, Professor. Do you see a lot of cases of segment 4 necrosis after split liver resection from your experience?
Segment 4 necrosis after a split procedure between left and right lobe?
Yes.
No, I can't remember.
You don't have a lot?
No.
Okay, I have also.
I did around 50, 60 split procedures, but I can't remember that I have seen segment 4 necrosis. No.
Okay. One also of our friend from Saudi German Hospital in Jeddah, the surgeon Dr. Amr Dargham, asking you, what do you think about R1 vascular resection result in comparison with R0 resection in colorectal liver mets?
The comparison of R1 and R0 resection.
R1 vascular resection with R0.
What means vascular? R1 vascular? If there are cells along a vessel, or what does it mean? Yeah.
If there is things all along the vessel, so you make it R1 and you leave the vessels.
Yeah.
And the extensive R0 resection, the outcome of in comparison of these procedures.
Yeah, I would always go for R0 resection. This is by far better than an R1 resection. If there's no other chance, I would prefer R1 resection over no resection, as I pointed out. If I'm really close, if there's no other chance, and there's only, let's say, the left liver vein or the right liver vein in place, and there's no other chance than to leave it, and I'm very narrow to the tumor, then I would try to take away as much liver parenchyma as possible around the vessel. And the best means to do this is ultrasound dissector, the CUSA. I'm not really a friend of CUSA. This is expensive, and for most liver resections, there's no need for CUSA. But in such a special case, I would use it to go along to clean up the vessel from each and every cell which is there. Nothing else is better than a CUSA in that situation.
Thank you. Our dear panels, do we have any question?
No, thank you.
Okay, I would like to thank Professor Hans for this very excellent and nice presentation, our panels for your joining and your nice question, our audience, and thank you everybody. Just I want to address a small message before we finish. For or non-surgeon or general surgeon, non-oncology surgeon, please do not take the decision by yourself. When you see a patient with liver mets and say this is a game over, no, the game is not over yet. Please send the patient to higher center with a good oncology and hepatobiliary surgeon, like for example, Saudi German Hospital, and and please, the patient still have a hope. The game is not over. Thank you, everybody. Thank you, Professor Hans, Dr. Ihab, Dr. Nadim, and Dr. Basim, and our attendee.
Thank you.
Thank you.
Thank you.
Bye.
Thanks a lot.
Bye.
Bye.
Assalamu alaikum.
Bye.